Welcome, everyone. So we have a exciting session today for the Fresh Air series. And so today we're going to do some spotter cases. And so in these spotter cases, these are cases that you can diagnose based on just the H&E stain alone in about 1 minute or less. And so these are types of questions that might commonly appear on different in-training exams that you might have during your residency training, and are important cases to know for practice as well. And so what we're going to do is we're going to each take a turn sharing cases, and then we're each going to put up our sticky notes with our answers, and then we can see what we all think, and then we'll discuss the findings. And so I'm going to do the first case here. So I'm going to make up a history for this that fits the case. So it's say a middle-aged woman with an isolated mass in her lungs and undergoes a wedge resection for it here. So I'm not going to really describe the microscopic findings. I'm just going to move around first at kind of low power here to show the overall features of the lesion here.
Residents, if we all get all of these wrong, then they are not spotters.
Yeah.
If we get them wrong, then they're not spotters.
Yeah. So hopefully we didn't pick too many hard ones, but yeah. Okay, so that's there. So I'm going to go to a little bit higher power here to show some of the different components within the lesion here. So we have areas that look like that. We have areas that look like this, areas that look like this, and then importantly, so I'm just going to move around a little bit to find these areas. And so we have areas that look like this as well. So I think this one's fairly classic, hopefully. So what do you think, Sanjay and Arnie? So we have hamartoma and hamartoma. Perfect. Great. So yeah, that's exactly what this is. So I think this is a classic spotter that can commonly occur in practice or on exams. So we at low power have this really nicely well circumscribed lesion that's composed of a mixture of mature cartilage tissue, this other more loose chondromyxoid type of tissue here, as well as mature adipose tissue. A key point in these is that you can also get entrapped bronchial epithelium here, so don't get dissuaded by this and don't end up calling this malignant, right? So this is an important diagnostic feature of these as well. Anything you want to add for this, guys?
Have you had cases where there is no cartilage only, or no fat tissue? I mean, only the fibrous tissue and the bronchial epithelium?
Yeah, I've had some where the components are in relative less. I think you start worrying about like if it's just cartilage, like a chondroma.
No, I mean without cartilage.
Oh, without cartilage, just the fat?
Like an adenofibroma. Only the fibrous stroma and the bronchial epithelium.
I haven't had a case like that. Sanjay, have you?
No, I haven't either. Actually, if I have that, I suspect that, that's one setting in which you suspect a metastasis. If you've got a spindle cell lesion with entrapped epithelium and nothing else. But I do have had cartilage poor, so no cartilage, only the myxoid stroma and fat. And that's the long course. That's the case I presented at the evening session at the USCAP.
Yeah.
And in that case, the epithelium was misinterpreted as adenocarcinoma on frozen section.
Mm-hmm.
That was a great teaching point.
I have had, I tweeted once one that was polypoid in the bronchi that had, and it was not a solitary fibrous tumor or so. Then I ended calling that adenofibroma, but I still don't know what it is. But
yes, there is a series, isn't it, Irene? Aren't you a co-author on that series of adenofibroma in, what is it?
Yes.
Is it or human pathology?
Yes, we later had some, not only I had that one in the bronchi and others in the middle, just the fibrous stroma that was proven not to be a metastasis by some immunohistochemical, and because the patient had not another malignancy anywhere. We have had like few like that I sign out like hamartomatous lesions, but there is that name, adenofibroma.
Yeah. Cool. Okay, so let's move on to the second case. So here we have another surgical wedge from the lung. And so this one we'll say is in a man, in middle-aged man as well. And so here's the low power appearance here. Moving down to a little bit higher. And I think I highlighted a few areas. Oops, sorry. So there's some cells that look like this. And then there's also some vessels or remnants of vessels that look like this. Okay. Do you guys have a answer you want to put up? Or
I need sometimes to write it.
okay.
Sometimes to write it.
Okay. Sanjay's got his answer. I won't say it. Yep, GPA and GPA. Yeah, so that's what this case is. And so I think the clues that I recognize at this case is at low power, it looks really blue. And then you have this, that's often described as geographic or serpiginous necrosis across it. And then to me, the giant cells also have a somewhat characteristic appearance where the nuclei tend to be a little bit more hyperchromatic, and they tend to be all kind of pushed to the side as well. And then when you go down to higher power, you see all these neutrophils everywhere as well. And then that vessel I showed over there shows a vasculitis as well. And so this would be a case of GPA or suspected to be GPA.
I'll just say that, you know, for a spotter quiz, like a board exam thing, this is a very fair question. But in real life, I'll say it's very, very difficult to find something as GPA.
I agree.
Yeah, no, definitely. I think in real life, I would, you know, you have to correlate with the whole clinical picture and everything, and you know, probably would be more descriptive. But in the standpoint of the exam world, where it's like you're writing the one best answer, I think that's what I would do.
Yeah.
I always have to think before writing granulomatosis with cholangitis and not to put Wegener on that. Okay.
Yeah, it's true. Go ahead.
I was advised not to call Wegener when you found well done granulomas. Do you have the same impression? That yes. Well-defined granulomas are not a part of granulomatosis with cholangitis?
Correct. Well-formed non-necrotizing granulomas.
Yeah.
Right?
Well-formed non-necrotizing.
Yeah, well-formed non-necrotizing granulomas away from the main lesion is actually a very good sign that you're dealing with an infection, not with Wegener.
Yeah.
Very reliable. In fact, you know, the reason I'm so careful about Wegener's is because I've seen many cases over the years where infection is misdiagnosed as Wegener's, and you know, and you find the bug later. So, and many of these features that are described in Wegener's overlap with infection. So once you see a couple of those, you are not so cavalier about diagnosing Wegener's anymore.
And in real life, you'd probably still do the bug stains and everything, right? So.
Yes.
And I don't think medical doctors would trust as much with that. I think if we say Wegener, they would try to prove some. Yeah. It's not going to be only Wegener because the pathologist says, but it's a bad mistake. It's a bad mistake to make.
Yeah. They'll still do serology and everything and rule out other causes. But yeah, great. Okay. So moving on to the next case here. So we have another surgical wedge biopsy. And so we're going to say this one's from a middle-aged man who has interesting occupation. We'll leave it at that. And then so.
No.
Yeah, so moving around at medium power here. We see all this stuff here, all these cells like this, as well as in the interstitium. Do you guys have an answer? Do you want to see more of it, or? Exogenous lipoid pneumonia, Yeah, exactly. So we're going to say for the standpoint of teaching, his occupation, he's a fire breather and drinks in the hydrocarbon liquid and then blows it out as a fire breather. And so
I thought you were going to say his occupation is sitting on the pot and straining for a long time.
no,
And then he
for the
needs to take
mineral oil aspiration, yeah, no, that's probably the more likelihood you get it. But you know, the differential is fire breathers, right? So you know, the people who are in the circus and drink the gasoline or whatever, and then spit it out, and they aspirate some of it, and they get it into their lungs. And
Yeah, such a good case to know, Matt, you know, because, you know, with the COVID thing, and not with COVID, with the vaping thing,
yeah,
how people badly misinterpreted foamy macrophages as exogenous lipoid pneumonia.
yeah,
And I was just thinking to myself, man, if they had seen even one case of a real exogenous lipoid pneumonia, they would never make that mistake.
yeah, and I think the big things that differentiate is you see these coarse vacuolated macrophages that are in the interstitium, as well as you see patchy giant cell reaction to it as well. Yeah, so it's definitely a different case. I did have one case where a few years ago where someone got a exogenous lipoid pneumonia from some form of hash oil use, like where they were using a Vaseline or some other hydrocarbon as a way to extract cannabis products. And they were inhaling some of that and got a bit of an exogenous lipoid pneumonia from that. So I think people can, I think there's a broad things. And when I was in the Midwest doing my training, I learned that, you know, the Vicks Vapor Rub, apparently it's common for people to put that around their nose, especially elderly people, and then they can aspirate some of the Vicks Vapor Rub into their lungs and get a lipoid pneumonia as well, which apparently is a common thing there as well.
Yeah, well, my mom used to do that for me, you know.
Oh, really? Okay.
When he got sick and couldn't, you know, were
Yeah.
having congestion, she used to put it around my nose.
Oh, well, hopefully you didn't get too much in your lung.
In Spain, there was an ad that said, first, in the nose to breathe well, second, in the chest to whatever, and then in the back or something like that. Then they said how you should use it, the Vicks Vapor Rub.
Then on the head to think well.
Maybe that's my problem. I got to put more Vicks on my head. Cool.
I had one case also on that beautiful, and nobody they don't still believe me because it was like we received that as a mass.
Okay.
Was not in the appropriate lobe. The image was that, and it took me a while to realize what was happening. I saw the holes and I couldn't see what was happening. And I put this in the pathology set for residents, and they don't get it the first time they see. I have to show the giant cells around the empty spaces, and that case was very, very beautiful because it had the lipoid pneumonia and also had some food.
Oh, cool.
Oh, wow, yes.
Scattered food. Then that lady was aspirin.
Yeah.
And she had also she had a problem. I think she couldn't move well or something. She had a problem that she was a lot of time lying or something like that. But I said, and the radiologist was staring at me like saying, it's impossible. That must be a mass.
Yeah.
Cool. Okay, so let's move on to another case here. So this is, I believe this is an autopsy case here. And then we have areas that look like this.
You really just posted one like this on Twitter. I
know, but this one highlights an important point. There's actually 2 diagnoses here.
Yeah, like in her case. Actually, hers might have had 3 if I.
Well,
no, I think I saw what Matt meant.
Yeah, here, let me just find I thought I annotated these. I guess I did it. There we go. I found some good ones. There's one there. There's one there. Okay. Do you guys have the 2 diagnoses? Yeah. We got pneumocystis and CMV. Yeah, perfect. Yeah, so it's good. So so this kind of, you'd obviously do a GMS to confirm, but this frothy exudate within these alveolar spaces should make you really suspicious for pneumocystis. And it's always important, just because you make one diagnosis, that there's not another diagnosis there. And so, as you look closely, you'll see these cells here that have both nuclear and cytoplasmic inclusions here. So there's one example of one, and there's another example of one. And so these are kind of the classic viral cytopathic effects that you see in cytomegalovirus infection, CMV. And so just because you make one diagnosis doesn't mean there's a second one there. And so.
Is this an AIDS or?
I'm not sure the specific history of it. It's from a teaching collection I have.
Yeah, but almost certainly will be, right?
Yeah.
There's very, very few other settings in which you get this degree of immunosuppression, right? That you get multiple infections.
I have this. Actually the tweet I made it was like two of the patients had AIDS. The one with the pneumonia and the one with the granuloma, but the one with the granuloma was recovered, had not the low lymphocytic count that you need for having the pneumonia, was feeling well. Then my impression is that his immunity was enough to make the granuloma, to make that reaction.
Yeah.
Cool.
And the other case, the diffuse alveolar damage is an oncologic patient. It's another kind of immunosuppression, not that big.
Yeah.
Cool. Okay, maybe I'll do one more and then we can switch it over.
Why it's called pneumocystis? The cysts are the ones we see in silver, or is something related to its radiological appearance?
I think the radiology in the old days, there were some cases that had cysts, and in fact, even now, people from the radiology point of view show cysts. But I that's kind of become a historical curiosity, because you don't see cysts in most PCP, right? You see bilateral ground glass opacities. So I think that's it. Of course, there are cysts. The organism itself is a little tiny cyst, but I don't think the name comes from that. Matt, correct me if I'm wrong. Do you have a different understanding of it?
I'm not sure. I know that the name of the organism has changed based on its reclassification, because I think there's been a lot of confusion about what this actual organism is over time. So, but I'm not sure the exact etiology.
Sometimes there are different explanations for one term, just like with lipidic. People tell different stories about what lipidic means.
Yeah.
And I think this cyst is the same.
Yeah.
Right.
Okay, so I'll do one more and then we'll switch it over. So this one, this is a young female that presented with a pneumothorax. And
is that a cyst?
I don't know, maybe. So there's this area here that may or may not be a cyst. And then we should always look at the wall. So there's areas that look like that. And then I think there's some in this one as well. And then I think there's another cyst over here. Sorry, I'm moving around a fair bit. So what do you guys think? Lamb and lamb. Yes, perfect. Yes. So this is a classic case of lamb or lymphangiomyomatosis, which is a bit of a word. Well, I think it's why we just say lamb.
Tongue twister.
Tongue twister, yeah. When I was first a resident learning about this, I just heard everyone say lamb, and I thought it was like LAMB, and so I kept Googling for like lamb in the lung, like the animal, and I realized that the B is not actually in the name. So for all the trainees out there, it's just LAM. There's no B.
Pulpath is like a crossword or a letter soup. We talk like that, LAM, UIP, NSIP, but people are like, just what are you talking about?
Yeah.
It's an alphabet soup of things.
Yeah, it's alphabet soup. That.
So this is a cyst in the lung, and so whenever you have cysts in the lung, you always want to look at the lining of it and see the wall. And so in this, we have these kind of spindle cells that are focally present in the wall throughout, and then Yeah, and so this is characteristic features of LAM, and characteristically occurs in younger females. And then they often can present with like chylous effusions as well. So that's the other clue you might get in the STEM for these histories on board exams. And a young female that presents with a pneumothorax and a chylous effusion would be very suspicious for LAM.
And also hemorrhage, bleeding, alveolar bleeding, and this endogenous pneumoconiosis if they are bleeding a long time or something like that.
Perfect. Okay, perfect.
Do you stain this with HMB45 to prove it?
Yeah, I do, unless it's completely obvious, but in most cases I've done HMB45.
And if it's negative, have you had this experience?
I don't know, Sanjay, I haven't had any negative cases. Sanjay, have you?
Yeah, you know, that actually, because classically HMB45 is weak and focal in these things. So you want to have a better marker. So the one I use is cathepsin K.
Oh,
and that's a very good, you know, it's a very strong marker. The problem with cathepsin K is relatively new for this. So you don't really know what else could stain for cathepsin K besides this, but it's claimed, and at least in my experience, this is true, that it doesn't mark other things, and it marks these picomatous lesions. So that's another thing you could do in those negative cases.
I use also progesterone receptors. I think just to highlight the cells when and
yes,
with the
but
focal.
Irene, just one thing in that is that other things that are in the differential, like a metastatic stromal sarcoma, endometrial stromal sarcoma, or a benign metastasizing leiomyoma are also positive for ERPR. So you have to look out for that.
It's not a specific marker.